What else? When we talk about perfect patient position.
Centering should be correct.
Centering should be accurate as best as possible. Collimation, not more than 1 inch on all sides. Contrast and density, what do we mean by that?
Perfect KVK mark.
That is pretty sure.
S values within the range, right? And then we can also tell by looking at the image if it's good contrast or bad contrast. Good contrast allows us to visualize whatever we're looking at. For example, good contrast on a chest X-ray should look like what?
A wide range of grays and blacks and whites.
Okay, perfect.
What was the answer?
The lungs should be dark, and there should be faint shadows of the ribs through the lungs. And what else did we say last week? We should see the outline of the heart, air-filled trachea, correct? Okay, positioning. Apex to costophrenic angles, clearly visualized. And then 10 ribs, telling us that it was good breathing instructions. And of course, we don't want to see any artifacts such as the snaps in the bra, bleeds on the EKG, necklaces, good, yes. So, in the real world, of course, not all patients are perfect, and so sometimes our images are not going to come out perfect. But regardless, when we take an image and we notice that something is wrong, what are we supposed to do? Okay, something else.
Try to
Fix it, exactly. So if you take a chest X-ray and you notice that the patient has a bra, when they said, oh yeah, I took everything off, which happens more often than not. So what do you do? Just send it like that, or have the patient remove the bra or necklace, whatever the case is, and then repeat it, right? So basically an image should never have to be taken a third time because we did not accurately identify what's wrong the first time. Alara, remember? We're trying to, I know maybe Harris techs don't follow this, but yes.
So we're supposed to stop after the second, or
No, the point of the sentence is when you take an image and you notice something is wrong, and you know that you can probably remove it out of the way, then we can take our second image. But you shouldn't have to be taking images 3, 4, 5 times because you didn't do your due diligence and check the patient, right?
But if like let's say for a lateral wrist and they have a funky radius, you're trying to get a perfect lateral, but something is off and overexposed or whatever. Like when would you stop at 3 or would like just after the second?
So if it's strictly something to do with the patient positioning, maybe stop at 3. What do you think, Mr. Kwan?
So I have 2 thoughts on this. Number 1, you stop when the image is acceptable. When it's good enough to send to the radiologist and they're able to see what they need to see in order to make the diagnosis.
So if the tech.
Second thought is that after shooting your first image and realizing that something is wrong, making it not acceptable, you should only need 1 additional picture in order to get it to be an acceptable image. Which means you need to know exactly how to fix an image once you see something wrong, which is sort of the purpose of this class, to be able to identify issues with the image and also identify exactly how to fix those issues. If you are needing to take 3, 4, 5 pictures. Let's say you're doing a lateral knee. You see it's rotated. You try and unrotate the knee. You shoot a second picture. It looks even more rotated. You try turning it the other way. You shoot another picture. It still looks rotated. You shoot a 4th picture, and it finally looks lateral. That's on you. Because at that point, you kind of suck as a tech. Okay? Let's just be straight. You should not need to do 4 pictures to get a good lateral lead. Right? You shoot your first picture, you see it's rotated, you should only need to make a small adjustment and get it right the second time. Those are my thoughts on it.
I only asked because yesterday we had a lateral come in, or a wrist routine come in. I shot the lateral.
Mhm.
He didn't really like it, but it was really funky wrist.
Okay.
So he repeated 4 times and ended up using my picture.
Oh.
So I was just like,
What
and
is that
and he
necessary?
exited out his picture. So I was like, what was the point? Like, that is against, you know, Alara. That's against all the things that we're taught. Like, just for your pride.
Unfortunately, you will run into technologists that keep repeating images because they think they're going to get that perfect shot. But part of being a intelligent tech and having experience, for example, if I have a patient that's in a lot of pain and they can't properly put their wrist in the true lateral, I'm not going to shoot that patient 5 times.
Right.
I'm going to probably take 2 and then use my good judgment, put in my notes. That's it. If the radiologist wants another picture, they can always put in a new order.
Okay. If that were my comp though, and even though they chose the image that I shot, it's still not my comp anymore because we had to repeat, right?
Repeat, yes.
Okay, that's all I wanted to ask.
So, when we display radiographs, the rule of thumb is that it's generally oriented on our display devices or monitors according to the preference of the interpreting physicians, meaning the head radiologist. There may be different rules at different hospitals that you work at. For example, at Harris Health, for example, if you do a lateral elbow, a right lateral elbow, which way would the elbow point?
Towards the right.
Inside,
Facing this way, correct? Right lateral?
right.
But at MD Anderson, some of the radiologists prefer all of their lateral extremities facing west. That's just their preference. So it's not like if you see something done one way at Harris Health, it's going to be the same thing at all hospitals. It truly depends on the radiologist.
Is that post-processing or is that in the positioning?
Post-processing.
Okay.
So you would do the positioning as regular, but you would just flip it.
Okay.
Let's see. Anatomic position. So radiographs are usually oriented on the display monitor so that the person looking at the images, who is us, sees the body part as though facing the patient. Does that make sense? So general rule of thumb when we look at x-rays, they're usually oriented on our display monitor so that the person looking at the images, it can be us, it can be the radiologist, we're going to see the body part as though we are looking at the patient. And what do I mean by anatomic position? Oh, bad picture, sorry. Anatomic position, standing facing you with the palms out, correct? All right. Some important terms to remember, hopefully you remember them from first semester. Cranial meaning cephalic or towards the cranium. Caudal meaning towards the feet. We know what's right and left, hopefully. Proximal meaning towards the midline of the body. Distal meaning away from. What about medial and lateral?
Medial's towards the midline.
Laterals away
Away
from.
from.
Okay. Anterior, posterior, we should know this.
Front.
Anterior is the front, posterior is the back. Ventral, front, and dorsal is the back. For me, it's easy to think about the dorsal fin on a fish, like the little fin on the back. That helps me remember ventral and dorsal.
I get plantar and dorsal.
Confused?
Sometimes, I used to, not too much anymore. The plantar just.
Plant your feet.
Well, now I started to know you put your feet on the floor.
Yeah.
Dorsal is the top of your foot.
It also looks like a dorsal fin if you look at the foot. You know?
Okay, kinda, sorta. Sagittal plane. We should all be familiar with MSP and MCP. Sagittal plane divides the body into
Right and left.
So if I were cut in half, right and left would be sagittal. Coronal, front and back. So if I was cut in half with whatever device going this way, portion and a back portion. Transverse or axial plane,
Superior.
superior and inferior.
I ain't seen that in so long. Oh my goodness. It won't tell 55 pictures.
So, we're talking about how our images are oriented. So, we already said that, how do we view images? As though the patient's facing you, correct? So, this side is the patient's what? Right. That side is the patient's left. Okay. But, what projection can we assume this is? PA. How do we know that?
Clavicles, heart shape.
Yes.
Would the marker need to be also PA?
If it was, that would show you that it's PA. But as a general rule of thumb, how do we know that chest x-rays are done?
They're generally done PA.
Generally done PA. So if you don't see mobile or portable, you can assume that it's PA. Another way to tell if it's PA, we went over this last week.
The heart.
The heart.
Heart, stomach presence, liver presence,
No, I'm asking you, how can you tell if it's AP or PA?
Oh, the clavicle.
the shape of the ribs.
Shape of the ribs. Mr. Frank, do you want to explain that? Because I don't like looking at the ribs because it confuses me.
So if you take a look at just coming back to Jay's question real fast. You asked about the marker being placed PA on the PA chest, right?
Yes, sir.
So was this marker placed PA?
It doesn't look like it.
So what would a PA marker look like?
Backwards.
Okay. Was this patient PA? Exactly. If the marker is PA, when you flip it, now the marker looks AP. Just like when the chest is PA and you flip it, the chest looks AP. So this marker was placed PA. So,
I thought it would appear as if it was
Right?
the other direction.
as if you have a marker, right?
Oh,
And your marker is PA, and then you flip the whole image,
Yeah.
it's gonna look AP. So, the marker's fine. Okay, as far as the ribs go, right? You notice that the ribs curve like this, and then they curve down this way, right? You've got this nice curve that almost always is, that comes very slightly up and this goes down, 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 right? If you are shooting an AP, what usually happens is that this portion where it curves down flattens out. So now it goes like this almost, right? It's a lot more horizontal rather than curving down vertically.
So do you have an AP?
So on an AP, clavicles are gonna be higher. You're gonna not look over there like T3, T4. They're gonna be all the way up at like T1, T2. And then your ribs are gonna come this way and then they're gonna come straight back. In fact, they even sometimes curve back up a second time. It looks really weird.
Yeah, that's why I said ribs confuse me.
Mr. Fong, can I
Yes,
ask you a
Shaheen.
question? So if it is going downwards, the ribs at the back,
Mhm.
then we know that's a PA, right, sir?
You
And-
can reasonably assume it's a PA.
But
You
then
can't-
and then when we see the L on the top, then we say that it's a PA projection, but it has been flipped.
So the L on the top being like that, right, that doesn't tell you if it's AP or PA.
No,
Good.
but I saw from the ribs that it's PA, and then I see L there. That
Mhm.
means that it's an image that has been flipped.
Yes.
Is that what? At least that was I'll figure out.
That's a reasonable assumption, yes, or
Because
reasonable
that is always
conclusion.
bothering me. Like, why is it L?
So other than the ribs, can we just go based off of the clavicles? Would you just say that's good, pretty good?
So
AP or PA?
you need multiple things.
There's
And-
something else other than the ribs and the clavicles.
So Ms. Bonilla was hinting at this earlier.
The scapulas?
Yes. So in a PA position, remember we do the chicken wings? What does the chicken wings do?
It removes the scapula away from the
Scapula.
lungs.
So if you take a look here at this image, the medial border of the scapula is not in the lung field, correct?
Mhm.
It's out here. So that is another good clue that tells us it's PA. Another thing was the clavicles, like Mr. Fong mentioned. In an AP, the clavicles tend to be above the apices. On this image, you can see that it's below.
Does the first rib also look different?
All the ribs will look different.
On AP and PA.
Yes.
What's the logic behind the clavicles? Because I don't understand why they're in different spots.
If you just think about how the body is positioned, AP versus PA, right? If you're doing a PA, the chest is flat against the IR, right? Shoulders are forward. If you're doing an AP, the back is flat against the IR.
So kind of like lifts
So,
up.
so it's almost like a slight lordotic, right? Because if I'm standing straight like this and I put my back flat against the IR, I'm slightly leaning back.
Right.
So that's why the AP looks slightly lordotic, because everything's being slightly shifted upwards. Compared to the PA, where you're putting the front of the chest flat. Okay. Also, Ms. Bonilla mentioned soft tissue, the heart. How does the heart differ between AP and PA?
Well, is it magnified?
It's because of OID, and
Yes, on APs, the heart tends to look a little bit more magnified than on the PA. Okay, any confusion with the AP PAs?
That's the best.
Thank you, Mr. Fong.
Thank you, Mr. Khan.
I think Samantha had a
Yes.
question.
Yes.
So just for PA, clavicles below the PCs,
APCs.
yeah. Ribs are curved inward toward the ends. The gastric bubble, well, I guess on the left. Heart shadow on the left. It's less magnified than if it was AP.
Yes,
Scapula border is not in the lungs from the chicken leg.
correct.
Anything else for that we would need to know for if it's AP?
There's one that I mentioned. I don't know if
Yes.
it's valid. The right lung is always shorter than the left. lung.
I mean, it's gonna be on the right regardless if it's AP or PA.
It also depends on patient condition.
Would it be?
Mm-hmm.
Then how would the heart flip?
No, the heart's not going to flip. We were just saying that on AP chest x-rays, the heart is magnified. It's always going to be pointed towards the left, regardless if it's AP or PA.
Unless I thought that's only like the image comes out and we flip it on the thing.
So some equipment, it automatically flips it
Flips
for
it?
you.
Oh, okay.
Yes.
from last time I wrote this and I couldn't understand. PA ribs are kind of horizontal than AP. So now Mr. Fung just explained. So you can explain the front of the PA
So
ribs are
Mr.
kind
Fong
of.
said on AP projections, the ribs tend to be, you said more horizontal, right?
Yes.
So
The back
instead of-
ribs, sir, you mean, the back rib.
Both
No.
back and front.
Also, PA ribs are kind of horizontal than AP, is that?
No.
AP is more horizontal.
So if the patient was in an AP position, if the X-ray tube is facing me, the ribs will be more horizontal. On this one, it's coming down like this. So this is PA. But like I said, I don't like the ribs situation. All right, what projection is this? How do we know? It says AP mobile, portable x-rays. Hopefully you're not doing portable x-rays PA, those poor patients. And you notice how the heart looks more magnified? Clavicles, they're still kind of in the lung field, but they're not as coming in at an angle. They're more horizontal, right? And also, look at the scapula. You see the medial border is in the lung field? So there you go, that's an AP chest.
And that's because they can't, I'm sorry.
Yes.
No, go ahead, Jim.
Is that because they aren't really given the instruction to,
They're probably just standing like this.
yeah.
They're not doing anything with their arms.
I have a question.
Yes.
Are the S values different for portables compared to the range you gave us?
For
Different-
some, yes, it is.
So for the evaluation criteria, can we go like off of that? Because one of the chest X-ray, I think I had the S value at like 10,000.
Oh, that's probably a machine error. Yeah, because there's no way your S value should be at 10,000.
The image came out right.
That's Harris Health property.
So
That's dynamic
So when you
range.
say the S value was 10,000, were you looking at the S value on the machine you shot it on, or were you looking at the image on Synapse?
Image on Synapse.
Right. So the issue with looking at, okay, and you said it was with the portable machine, right?
Yeah.
So here's the issue. The information that we see on Synapse, the extra information, like KVP, mass, S value, how is the image able to display that information?
I don't know.
Where's that data stored? We talked about this back in PR.
DICOM?
That additional data on an image.
Is that DICOM?
DICOM, very good. Right, so the
Leave it up,
DICOM
leave it.
header is where the information is stored. Which means that the equipment needs to be configured in a way to send the correct numbers to the correct locations in DICOM. My suspicion is that these new machines, the portable machines, the new Philips machines, they have not been configured to send exposure index values correctly to DICOM. The only things that are sending correctly to DICOM are the old Fujifilm CR readers. So if you shoot it at an old clinic like Strawberry or Aldine where they have the old Fujifilms, the S values that you get, those are gonna be correct. But if you're shooting new stuff at LBJ or Bentov or on the portables, those numbers going across to DICOM, I do not believe those numbers are the correct numbers going to DICOM.
So what are
So
we
should
gonna
I get rid of the requirement to have S values on the images?
Yes.
Yeah.
Just
It's
make
very
it
selective.
get on the portable?
And it's
Yeah, 'cause my-
LBJ.
That's something we
We
can
can
talk
see
about.
all over the place.
That's something we can talk
We'll
Okay,
talk about it.
we'll talk about it in private, okay.
about. You got a question?
Well, I was just gonna say.
All right.
Some of my
Wait, Cody,
numbers, they don't have, where the S value is, there is.
Yeah.
Right, exactly.
Also.
So same thing, right?
That's fine.
Nothing's getting sent across to that DICOM.
Yeah, I was gonna ask that question, cause I got an example, there's no S value, yeah.
All right, what projection is this?
AP up.
AP, and we know that because
We do AP abdomens.
we only do AP abdomens.
Okay.
Skulls. What projection is this?
Open mouth.
I said projection, not position.
My fault.
AP, open mouth. This.
I'm saying PA.
Let me just,
Do y'all do your skull PA?
I think it's AP,
It should be AP.
Yeah.
because sing right there.
It's a deltoid. What do you mean a wow?
Oh, this is a skull, this is not a.
Oh,
They just open their mouth, but.
Yeah.
Put into it at
What's the confusion?
Okay, my text just.
What is this? AP?
AP open mouth, but we do open mouth AP.
We do everything.
This is open mouth AP.
Oh, I didn't know what.
And this is
AP pelvis.
AP pelvis. Obviously, we don't do PA pelvis, right?
No, I thought that, she said it would be skull, but I didn't do a skull open up, so.
My text just leave it open. We get the whole.
So earlier we said that usual X-rays for chest, abdomen, skull, etc. We view it as though the patient is looking at us, correct?
Yes.
Are there exceptions to that rule? Yes, obviously, because we flip the hands going up, fingers, wrists, feet, toes, and forearms. They're all hung differently. So these X-rays are viewed from the perspective of the X-ray tube, or how exactly the anatomy was projected on the IR. We know that hand X-rays face up, correct?
Yes.
So does wrist. What's that?
Elbow.
AP elbow. They're hung down. Right elbow is obviously going to face direction that it was taken, unless you're at a weird hospital. AP foot. AP foot is hung up, and then the laterals are hung whichever direction the foot is facing. what projection is that right foot?
The lateral?
Okay, I guess my question is specifically, yes, medial lateral. Why is it medial lateral?
Goes from
It's going through the medial.
No,
medial
Mama, I
to
didn't
lateral.
understand what the question is.
So my question was on this lateral foot x-ray, I know it's a lateral foot, but what is the specific projection? When we talk about projection, what are we talking about?
How the X-ray travels.
The direction of the central ray, right?
Mm-hmm.
So it's medial lateral because why?
It's lateral because it's coming on this other side. It's medial lateral. Is it entering the middle of the foot? I'm not sure.
So this is the medial aspect of the right foot.
And
Do
this
you
is
understand?
Is it the center? So it's medial lateral.
No, we're not saying medial lateral because it's going through the middle of the foot. It's entering the medial aspect of the right foot. Earlier we said, what's the difference between medial and lateral? Lateral's on the, away from the body, right?
Away-
So this is my lateral side, this is my
Away from
medial
the center,
side.
right, ma'am?
Yes.
And
Medial is closer towards the body. So when we're doing a right foot, the CR enters the medial portion and exits the lateral portion of that foot.
So how are you comparing that middle to the middle of the body, ma'am?
So
When you
on
say
a,
medial, it's the
okay,
middle of the
on your
body.
foot, which one is the medial side?
On this side is the medial because it's on the towards the middle of my body.
Right, so if I did your right foot x-ray, the x-ray
Or
would.
from this side will be from the medial side and then this
Yes,
side.
and it'll exit the lateral side.
Thank you.
And what x-ray is this?
Like forearm.
AP forearm. It's hung up.
Mm-hmm.
That doesn't look like a very good AP though. And lateral forearm is also hung up. You may see some texts hang it like horizontally. They flip the arm around, but this is the correct way. All right. So there are some rules as to how we should mark our X-ray images. Correct marker should be visible and demonstrate accurate placement. Ideally, where should you place your markers?
Lateral.
Or I guess my question is, where around the patient?
Outside the anatomy.
Outside the anatomy, on the patient, or on the IR? On the IR ideally, but sometimes the buckies don't let you put it on the detector itself, it won't let you close. So in that case, you would put it in the collimated light field on the table itself.
And sometimes you need to put it on the patient as well.
No,
That's fine.
you will see
Oh.
text, put it on the patient, but that leads to distortion, magnification, things like that. So ideally, you want to put it either on the table next to the patient or on the actual cassette plate that you're using. So if I ask you a question, what is the importance of placing markers on the IR instead of on the patient or on the table, you would give me these reasons. Avoids marker distortion and magnification. Also prevents scatter radiation from crossing underneath the marker and making the image look noisy or foggy. Okay, so this is a gold star question, I guess. All right, so take a look at this box on page 33. It will show up on your test, hint, hint. For AP and PA projections of your body, which includes both sides of the body. For example, chest, abdomen, skull, spine. Typically, the right marker should be used. Of course, there's nothing wrong with using the left marker. Lateral projections of the head and the trunk, which shows both sides of the body. What's the rule for the lateral x-rays? Whatever is touching the IR. So markers typically placed anterior to the anatomy. So if we do a lateral chest x-ray, which side are we going to mark?
In the front of the-
Left, and where are we supposed to put the marker? In the front.
Except
Okay.
for ribs, that's the only one.
Girl, don't confuse that.
It's the AP.
these are some examples.
Good
So we
Lord.
have, what, position is this?
T-spine.
Thoracic spine. You see that the right marker is placed, correct? Away from anatomy. We have a chest. We have the right marker. Of course, you can use the left. But typically they say to use the right marker. I don't know if there's any particular reason why, Mr. Fong. Do they say to use the right marker?
A particular reason to use right mark?
Mm-hmm. The only thing that I can think of for like pelvis, abdomen, is because most of the time you're closer to the patient's right side.
Try not to reach over your patient.
Yeah.
And for chest, we were told by Mr. Fung that it's better to use the left because in
You're
the
gonna use
lateral
it for the
position, you have
lateral.
to use the left.
What position is this? Looks like an APL spine. The only reason I say it's an L spine is because I can clearly see
5.
the bones better than the tissue. So it looks like they opened it up kind of like how they do it at LBJ. Don't they open it up?
Or can it be an F?
What do you
Yeah,
mean by
central.
or the collimation are you talking about?
Yes, collimation is very open, but this is a L spine.
It can be an abdomen because you don't see the
Diaphragm.
diaphragm, right?
It could be a AP supine since it shows the pubic symphysis.
That would just be the second portion of the.
Correct.
Good
Okay,
question.
Jay. All right, so how about oblique positions? How do we mark those?
The side that's whichever side is of interest.
So the general rule is the side closest to the IR should be marked. So for example, we do an oblique spine, a chest, or an abdomen. We always mark the side that's down or nearest the IR. We'll take a look at some images. If we do an RPO ribs, what side should I mark?
RPO, R, right side.
Right, because my right side's closer to the IR, right? LPO, left marker. What about RAO? Right marker. Right marker. Whatever side is closer to the IR.
Ooh, this is a RPO.
So this is, we're looking at what?
L spine, we're looking at the right side.
Oblique L spine. So how is the patient positioned?
RPO.
RPO, right? We see the right marker on there, which tells us the right side is closer to the IR. What if the marker wasn't on there?
Scotty dog in the hip.
Take a look at this iliac crest. You see it's elongated, right? Which tells me the patient's oblique towards the IR.
But how do you know it's the left or right? Because we assume.
The hip will be in, be bigger, and then you can look at your Scotty dolls. The Scotty dolls will tell you which direction.
Yeah, so for Scotty dogs, what did you guys learn in Mr. Donahue's class?
The nose is facing
That direction.
So you see the nose of the little Scotty dogs?
Nose is facing the right side.
Rib X-ray. First of all, what position is this?
Ooh.
The right is elongated, so left is touching.
So first things first, we see a right marker, which tells me what?
Right side is touching.
Right side is touching the IR. And you see the right ribs are elongated. So it should be what? RAO.
LAO.
Wait. So you said the right side was touching the IR, but the right side is elongated?
Yes, you see the ribs are
So
elongated
it's
on the
a
right side.
LAO. No?
RPO.
Oh, that's RPO?
So if my right side's touching,
Oh, yeah.
and then a posterior oblique,
Yeah. Oh, yeah.
Oh, okay.
I feel like I probably lost somebody on that.
So this is an LPO,
Okay,
not an
focus,
RPO.
focus. Here, posterior oblique of the ribs, the side that touches the IR is elongated. Anterior ribs, the side that's away from the IR is elongated.
So the right side's down, the left side's down.
That's what I thought, that, I remember saying that you mark the side of interest. Is that not correct?
No, he said mark the side that's touching the IR.
No, one of them we did say.
Yeah, the side that is elongated, that's the side that you mark.
No. He said the side that's touching IR.
Mm-hmm.
But if it's the same
No.
size,
It's elongated.
okay, well, what is it? What is it?
Well, the
I think he
rule
said
is, the rule is whatever side is closer to the IR should be marked, period.
That's also the side that's elongated.
No. Depends on if it's anterior or posterior oblique. Alright, for extremities, how do we mark them?
Whatever anatomy you're taking pictures of.
Anyone?
Right or left, depending
I
on.
Right or
don't know.
left, depending on what anatomy you're x-raying. So, left foot, we put the left marker, super easy. Left knee, we put the marker that's the left. And then on the lateral, what did we say? Anterior to the anatomy, remember? If we use, or if we x-ray both of the anatomy in one plate, we're supposed to mark both extremities. So for example, bilateral knees, don't just mark right, you're supposed to put both. Hopefully the techs do it this way.
Eval does it like that, so I was doing that in strawberry, and she said, you don't have to mark both of them, just mark one of them. Not every tech is the same.
Not every tech is the same.
As long as one is marked,
Alright, our favorite, what position is this?
Decubitus.
Decubitus, okay. Decubitus of what?
Abdomen.
Abdomen. Alright. Which side is up?
Right.
We know that because the right side is marked, right? Would we be able to mark the left side? No, why not? It'll be the anatomy.
How do you know that was a decubitus abdomen and not just a picture someone turned
Because of
inside?
the air fluid?
I see like the stuff at the bottom.
Because the marker's
Yeah, they've been built
standing
up.
straight.
Yeah, the
I'm
sheets.
gonna turn it. Alright, so, okay, I heard air fluid level and I heard something at the bottom.
Yeah, the
because
sheets,
of
they
the
was built
sheet
up.
that's going up.
Yes, very good. So you can see the artifact from the sheets holding up the patient. And yes, you can also see the air fluid levels in the colon there.
Where's the
I'm having
F3
a,
level?
yeah.
So like if you look at the very top at like the
Oh, right there. I see it right here.
there.
Remember to look for air fluids, you look for that flat line. There's a flat line right there,
So that's not
and where
the,
else?
I'm gonna say what poop.
yeah, that's the bolus.
When they might have to poop.
F3 level is
'Cause-
not that clear though.
It's not.
The sheets are good though.
The sheets are a good way to identify it, but if you were looking for air fluid levels, you will see a straight line between the air and the fluid. So you see a straight line right there, correct? Where else do you see it, Mr. Fromm?
Yeah, so I think it's like there and then along the left side where you were pointing as you follow that colon down towards the left.
Towards the
There's a whole
sigmoid?
bunch of air fluid. So, not sigmoid, it's more like towards the.
Oh, right there?
Where?
So,
Oh.
yeah, I mean, I'll be honest, right, kind of like Shaheen said, some of these air fluid levels aren't the most clear. And that kind of brings us back to something we discussed back in semester 1, which is when we do either an upright or a decubitus for air fluid levels, what is the optimum time to wait for those air fluid levels to settle?
5 minutes.
5 minutes is the minimum. What is the optimal time though?
20.
Like 15 to 20 minutes.
And you
Now,
don't
of
want to
course,
wait
is
that.
any department gonna let you leave
No,
a patient lay on their side?
they don't even let you wait 2 minutes.
Bye.
Right, so that's why a lot of times you're not gonna see optimal air fluid levels.
Alright, so,
Oh, look at the baby.
Look at the pelvis.
so this is a decubitus position done on a pediatrics. What
No, there's
position
no
is this?
sheet.
Hold on, what position is this again?
Chab.
What?
Decubitus chab.
Yes.
Left lateral decubitus, left side's down, right side's marked up. Does anyone know why doctors prefer the left lateral decubitus, especially if they're looking for free air.
The heart and the gastric bubble.
Because of the gastric and the stomach.
What about it?
Because it can,
You had half of it, go for it.
They go up.
like they can mistaken it for the gas.
Yeah.
So if they're looking for free air in the peritoneum, in the abdomen cavity, if they lay on their left side, the air is going to come away from the stomach,
And the fluid goes
and then
in.
it's going to sit right up there by that shadow of the liver. So that will clearly help them identify if the patient does indeed have free air. Because if we do a right lateral, what's on the left side of the patient? The stomach, which you normally find air in, correct? That's why they want the air away from the stomach area to come to an area where you normally don't find air. Okay? All right. So, rules for decubitus, always mark the side that's up. Place markers on the side up, away from the anatomy of interest. What is the big importance of correctly marking your images? Legal purposes, you don't want to be sued. What else?
Because it might be flipped and you might not know what's going
For the sake of the patient.
Well,
Just
for the sake of the patient. For example, there has been many cases where anatomy was mismarked and that led to the patient having surgery on the wrong anatomy. So you don't want that to happen to you. I mismarked an image once and I learned my lesson. I took a skull X-ray and I got super confused and I mismarked it and ended up being called out by the radiologist. So I was like, never again. Yes.
was
I got a verbal warning.
Was it the physical marker or was it?
I did it digitally. So basically I didn't use my own marker, and when the image came up, I was like, wait, this was done in AP, so is this the right side or the left side? Or did the computer flip it? So I was just confused. So use your own lead markers. Some examples of what not to do. Upside down pelvis, and then we have some upside down annotations. And a marker.
So, ma'am, upside down marker would be an unacceptable image.
Yes. That is not something that we want to call optimal. We have a really wonky looking abdomen, but the right marker's right there.
They got their legs open.
Yeah.
That's that freak position.
Y'all look like Optimus Prime.
That's most likely an ad.
Yeah. Okay.
And then we have a really nice marker in the middle of the anatomy. What projection or what position is this?
Waters.
Water. So look at what?
Air sinus.
Sinus. Who can I ask? Shameka.
I close my eyes.
What are these?
Those are frontal.
Yes.
Frontal sinuses.
John's.
Uh-oh.
Maxillary sinuses.
Okay.
Okay.
One more.
Samantha,
No, like,
what are these?
That is is it like lacrimal? Lacrimal bones?
Not a bone. We're looking for sinuses.
Sinuses. That is the sphenoid. No, it's near the eye.
Ethmoid. Spheno usually sits behind the ethmoid, so you wouldn't be able to see it on this.
But if you open mouth, it's a sphincter in the mouth.
Mm-hmm.
Oh.
On this image?
On this image, it's in the mouth.
Ooh.
Like underneath the teeth,
Not
right there.
Right there?
What's the phone?
Huh.
What
Well,
is
you guys
that?
did not know that. Thank you.
Discord cannot.
What's the mark?
Where is the sphenoid sinus on this image?
Got him. Uh-oh. On the phone. Mm-hmm.
Take a really good guess.
Because there is a.
or your license gonna get revoked.
Hey.
Not the license.
Most likely behind
Oh, he knew it.
That's what he heard it.
Miss Bonilla, orbital sinus is a thing, right?
Monty texted.
Orbital sinus.
Orbital sinus.
Is that a thing?
Stop here.
Not that I know of.
All right. All right. Orbital sinus.
All right, you guys can take a 10-minute break. And then you will have about 30 minutes to work on your projects, and then Mr. Fung will be here for study hall.
Since Mr. Fung is here now during our break, can we do yoga or like how's this working out?
It's up to you.
Stretch.
We're not doing stretches no more?
I mean, sure, everyone get up.
Can I go to the?
It's stretching time.
I'm gonna